you don't mind, I'd like to start with you, Kwame. Now, so many times we have had conversations about preventive medicine and the fact that it's almost non-existent in our policy making here in Ghana. In other parts of the world, it has been used to great success. In the UK, the conversations even continue about how they can do better. Finland is a model country for this. So is Japan. So is Singapore. Will Dr. Abuosi Da Costa's idea of one free health check per year, will it be enough to save the public purse?
Well, thank you, Kojo, and good morning to listeners. Yes, there is enough evidence to show that mass screenings drive down healthcare costs, and I'll explain. If you look at a disease like diabetes, they would always tell you that over 40% of diabetics are walking around without knowing that. So you are diabetic, and that's why I started from that point. They don't even know that they are diabetics, and they would only find out accidentally. The same thing happens with hypertension and a lot of cardiac diseases. So you'd realize that sometimes someone will be walking around or go to the gym and people will be saying, oh, he's an otherwise healthy person, and might get a cardiac event and unfortunately be hospitalized for a long time, or in worst cases, pass away.
Yeah.
But they would have had telltale symptoms, sometimes a random morning headache or something that, like I was listening to all of you at the start of the program, and Raymond was saying that a guy would only go kicking and screaming to the hospital.
Yeah.
So when they get these symptoms, they'll take some paracetamol or some ibuprofen, and as long as it knocks it off, they do not bother that what is the underlying condition that is causing me to get these headaches. So they wouldn't go and check. So all these people are walking around unknowing, and often when they get picked up accidentally, the cost to the healthcare purse is higher because they have to go sometimes straight into what we call secondary care.
Yeah.
And the cost of secondary care, which is hospitalization, often is higher than primary care, which is where you are being managed in the community. So what mass screening does is it identifies the sick healthy long before they have to have a health episode and go into secondary care. And when that happens, they can be put on what we call first-line medications for which category, ever category of disease they find themselves in, whether it's diabetes, whether it's hypertension, you name it. They can be put on the first-line medication. And often first-line medications are relatively cheaper.
Yeah.
And because they can be put on the first-line medications early, their prognosis, that is the outcomes they will get from the management of their disease, is also better. And they do not then go into secondary, tertiary line medications, which would have a hit on their purse if they don't have health insurance, or if they do have health insurance, have a hit on the health insurance purse because often those are specialist medication. So if the NHIS is able to do this and screen en masse and identify these people, some even would be identified as borderline. Borderline means they are not actually hypertensive or diabetic, but they are getting to the point where they need to be monitored.
Yeah.
Then there can be what we call a recall process to bring them in from time to time and nip the symptom in the bud the minute they cross the threshold to become a chronic disease patient. So countries that have done this, in the end, have increased their life expectancy. They have decreased the cost of their secondary care because fewer people go into hospitals. And also, they have increased the quality of life of their citizens because what we call their quality adjusted health years, that is the number of years you stay healthy compared with the number of years that you would live on this world, is higher. And therefore, they are more productive to the society by way of working longer, paying taxes, and generating wealth and all that. So if you look at it from that broad-based idea of preventative medicines, then Dr. Abuosi Da Costa is spot on. The next question we go to will be, how do we operationalize it? And how do we fund it? So that is where I'll leave it for now.
Okay. And Prof. Abuosi joins us over the phone. Prof, I wonder, it seems such a simple, logical step. Why has it taken this long for the National Health Insurance Authority to start prioritizing preventive health?
Good morning, Raymond, once again, and good morning to the colleague who has spoken so well. Those are some of the issues I would have mentioned, but he has done justice to his analysis. Let me start by saying that it is late, but it's better late than never. Our medical system or our healthcare system is too much skewed to the curative healthcare rather than the preventive healthcare. I know that some years back, the Ministry of Health, under the auspices of the late Kwashika, who tried to introduce what we call the regenerative health and nutrition concept by the Ministry of Health. But it's like it wasn't given sufficient push, and we've gone back to the curative aspect of care rather than the preventive. If you go to our hospitals, it's all about detecting what the diseases are and then giving medications. And there is little that is done to encourage people to test, to come to hospitals and clinics and so on to test for their diseases. They have even, in case they have underlying conditions, they have even posted dietitians to some of the hospitals. But if you interact, some of them are my students. They are sitting down there. They don't refer cases that need diet counseling and so on to them. People don't take these silent killers, diabetes, hypertension, and so on. They don't take them serious because they don't perceive it as threatening. And it's a combination of ignorance about the prevalence of the non-communicable diseases, and then the fact that the diseases that don't pose a threat, like you don't have fever, you don't have headache, and so on, people don't take it serious. And let me give you some few statistics. It's very frightening. There's always a global burden of diseases that is done. That is usually 10 years. And in Ghana, when the global burden of disease studies was done, between 2009 to 2019, listen to the startling statistics. You will see that when we look at the causes of death, the most causes of death, malaria is number one between 2009 to 2019, but it dropped by over 33%, almost 34%.
Right.
Stroke increased from number 5 in 2009 to the second position.
Whoa.
And it increased by 25.2%. If you look at the lower respiratory tract infection, it dropped by 0.5%. Neonatal disorder, these are non-communicable diseases, dropped by 18.5%. If you look at ischemic heart disease, that's a heart conditions, apart from stroke, it increased by 37.6%, rising from number 7 cause of death to number 5. And then you come to diabetes. Number 9 cause of death increased by 24.6%. And then cirrhosis of the liver, 12.3%. That is rising. So there is what we call the epidemiological transition. That when a country is developing, the diseases that are communicable diseases give way to diseases that are non-communicable diseases or lifestyle diseases like diabetes, hypertension, and the other cardiovascular diseases I've mentioned, kidney diseases, and so on. So you see that Ghana is on a ticking time bomb. We have a serious epidemic of overweight. and people are walking and are at risk of getting type 2 diabetes, and they don't see it important to go to the facilities to check their BP, check their weight, so that they'll look at their body mass index and be able to predict their risk of getting hypertension or diabetes, and then do what we call primary prevention. Primary prevention is to make sure that you check, and if there is the risk of getting the disease, then they will already talk to you about diet, they will talk to you about exercise, and so on and so forth. Then you will never get it. So we are used to this secondary or tertiary prevention, where the thing has already happened, and now we want to solve it. And like my earlier speaker said, it is more expensive and more difficult to deal with the secondary and tertiary prevention level than the primary prevention. So what I'm seeing that the health insurance wants to do is to promote primary prevention, so that every Ghanaian will have the opportunity to be checked. And then I understand, I'll check at Ghana Web and saw they are saying that if they check them at the health facilities, those who don't have health insurance, they will use the opportunity to register them. So they will be killing two birds with one stone.
Right.
And so when they do that, then it means if the growing trend of non-communicable diseases, which is more expensive and more difficult to treat and will pose a big burden on the health insurance scheme, if they are able to do this, plan it successfully and qualify people through health education, and people go and test for their, and then they will see that those who are at risk of developing diabetes, hypertension, and all these other statistics I'm giving you, and it drops down. I tell you, even it will lessen the expenditure, health expenditure on the health insurance. Yeah. That's not to say that it's an easy task. It's very good. They have an uphill task. As I earlier said, people don't get convinced with things like, go and do exercise, change your diet, and so when you refer people, they don't go. When you talk, it needs a lot of education because they don't see any threat to their lives. But I tell you, it's a silent killer, and Ghana is on a ticking time bomb because of the rising incidence of non-communicable diseases. Right. And so what the new CEO is coming to do must receive so much support from government, from all stakeholders, including the population. It's a step in the right direction. I understand that he has a background in health promotion, and I'm not surprised that he has seen that it is a big gap that the health care has provided. So if they put their measures very well, I'm telling you the benefits are going to be so much to Ghanaians. Yeah. Many hidden diseases will be exposed, and they will screen people for cholesterol and then so many other things, cancer, and the rest that will help us to live longer in the country.
Yeah, so very important point. Thank you, Prof. We are also joined by Dr. Yaw Osafo, another guest who needs very little introduction. He's the Drive Doctor. You hear him once a week on Drive Time on Joy. He's the medical director of Medicas Hospital in Mampong. Doc, good morning to you.
Good morning, Kojo, and good morning, Raymond. Good morning to all our listeners.
Yeah.
Kojo, how are you?
I'm very well, Doc. It's great to hear you on our show once again.
Good to be here.
Now, Doc, one important point that Prof. Abuosi made was about what must happen next if indeed this policy of the free health checks, if it receives patronage. These health checks will result in doctors like you recommending healthier habits for your patients. Right. Things like exercise and, changing their diets and all of these things. Doc, in your experience, how easily do Ghanaians adhere to such advice?
Well, thank you, Kojo. You're putting me on the spot. Wow. It's good we're having this particular conversation regarding healthcare and the different types of or the different approaches to healthcare. I think traditionally the focus has always been on curative medicine, and we've paid relatively little attention to preventive and then promotive health. So it is a call in the right direction. I believe every healthcare professor, every doctor will support it, because from where we sit, most of the time in the clinical space, then you don't want late presentation of disease, or you don't want to be treating patients when they have developed complications of the disease. It makes your outcomes very, very poor, and it makes the work a whole lot difficult. And you don't want either of these two options. So, Kojo, let me talk about the health-seeking habits of the Ghanaian. And this April, I've been doing this work for 18 years. So I know a bit about the health-seeking habits of the Ghanaian. I think earlier in the on the show, Raymond perfectly described the male adult Ghanaian as health-seeking habits. And it's very, very different from the female adult Ghanaians' health-seeking habits. I think we need very good research to understand why the differences. Because, Kojo, when it comes to the health-seeking habits, the men are relatively financially empowered, and adult females, don't have the same economic or financial muscle as their male counterparts. So you will think that since healthcare has cost implications, the men would rather jump at it and frequent hospital more. But in all of my practice, every month I look at the statistics in the 9 years of Medical's hospital. It is overwhelmingly female attendants higher than male attendants. So the health-seeking habits of the Ghanaian ought to be better than what it is right now. I was trying to send a picture, and I'll try maybe later on if we have a break, try and find the picture for you. But Kojo, it's a picture of what we see with breast cancer presentation typically in this country, with the entire breast completely ulcerated. I've seen breast cancer with maggots coming out. The late presentation, I think last year, we all got to know a bit more about chronic kidney disease. And again, we get to see patients coming in with stage 4, stage 5 kidney disease. In that stage, and that's the terminal stage. Stage 5 is what we call end-stage renal disease. When patients come in at that stage, then there is very little to do. Then we'll call on dialysis, which is very, very expensive. So last year, for example, that whole conversation about dialysis typifies the need for us to focus a lot more on preventive health. The attitude needs to improve. In my experience, most of the time I'm told, doctor, the intimate hospital, na doctor can't say well, that's the gist, that's the summary of the attitude for most. And we need to change that through health education.
Thank you. Kwame, it's good that you can give us the perspective of what happens, across the globe, so that we can put our own experience alongside it. Now, not for the first time, I'm going to cite the example of the NHIS in the United Kingdom. And this drive that started sometime back in 2005, I believe, this 5-a-day drive, the idea being that every British citizen or every resident of the United Kingdom was not just encouraged, but pretty much required to consume 5 portions of fruit and or vegetables a day. And there were TV promotions, radio adverts explaining to the British people what makes up a portion of fruit and vegetable, and how they can source those portions in their daily diets, and what changes they needed to make in order to meet 5 portions a day. And the market responded. So people started branding their products and saying that, oh, this product will give you 1 of your 5 a day, or this other one will give you 2 of your 5 a day. And they were pricing their products accordingly so that someone would spend a bit more money on something that will give them 2 of their 5 a day as compared to something that will give them 1. So the whole nation responded. And today, it's almost as if a law was passed. It is just in the back of every parent's mind that their children must have 5 portions of fruit and vegetable a day. Please tell us, using that example and its effectiveness in the UK, should the Ghanaian NHIA be thinking of supplementing this free health check idea with some of these proactive policies? And will they work on Ghanaians?
Well, Kojo, thanks. You see, we all agree on one thing, that our health-seeking behaviors need to change. And if you look at it, health-seeking behaviors do not change by coercion, they change by education. So you use the example of the UK when the adverts for fruits and veg was going on. I can tell you now that for most supermarkets now in the UK, when you walk in, and all of you have been here so you know that, you would find that there's free fruit for children. The supermarket it's selling fruit, but it also has free fruit, so that even while the children are walking with their parents and shopping, they can pick from the basket that says free fruit for children and eat it there. A clean fruit ready to be consumed. What are they doing? They are inculcating the behavior into the children at a very early age. Habits are picked early in life. As it stands now, it would be very, very difficult, especially for most adults who have got their palates well chilled, to teach them, especially less adventurous adults, to eat new things that they are not used to. I mean, if you want an example, you see that when restaurants come to Ghana, how many people would go into a Chinese restaurant and try, mixed fried rice? I remember once I was in France and I was with some Ghanaian colleagues at the conference. And we went into a Chinese restaurant and I said I wanted mixed special fried rice. And one of them said, na Kwame pardon our person would be. And I said, oh, mixed fried rice. I said, yes, I'm going to be a potro. You see, so immediately, because the French are known to have a delicacy for frogs, the person was assuming, oh, I wouldn't try just in case I eat it. And what made it worse was another colleague I was with, who works with me, ordered for squid ink rice. I don't know if Kojo, you've seen it. They cook the rice and they use the
ink, the black ink from the squid. Yes. Yeah. And
that threw the rest of them off. And why am I saying this? I am saying it because we are traditionally not adventurous eaters.
Yeah.
So, and that is why I'm happy that Dr. Da Costa is saying this now. So the education, and that was why I left it at how do we fund it and how do we operationalize it. The operationalization should start from our schools, from the JHS and SHS, whilst trying to change the, health-seeking behaviors of the adults. Because if you look at Ghana, our population pyramid, our median age is around 20.5 years, which means we have a very young population. And we know that a lot of these chronic diseases start when you go past 30. In fact, in the UK, at age 40, it's mandatory that your GP should call you in for a mandatory health check. You get invited on your 40th birthday, whether you are sick or not, to come in for a total health check. So if we want to do this fruit thing, that is what we have to do. We have to target it so that when the children get to about 25, 26 in the university, there will be a critical mass of Ghanaians building who are conscious about fruit eating, who are conscious about vegetable eating, and who would have picked the conversation about the doubling of our disease burden. What I simply mean by doubling of our disease burden, we already have the infectious diseases. But now, because our population life expectancy is increasing and our sedentary lifestyle and other things, we are getting these chronic diseases layering over the infectious diseases that we have. And this doubling of the disease burden is what is causing the problem. So we need to get the children and the young people to understand. And when they do understand, and when they are proactive seekers of healthcare, what will happen is that what's called our outpatient per capita, the number of times that citizen sees a health professional annually would increase. Currently, it's about 1.1, 1.2. We need to start inching it towards 4 once every quarter. If that starts increasing, then the health professionals would also pick these diseases. And the beauty of it is that for many of these screenings, it shouldn't be done by the doctors or consultants and all that. They can train what we call middle-level cadres, nurses, nursing assistants and all that, because things like taking phlebotomies to take the blood pressure, your pulse rate, cholesterol level, all these things in the UK are no longer done by, the high-level health professionals. So we need to have a comprehensive thought-through implementation, not just the promotion of fruit, but target the children in a holistic manner so that they understand. And also you tune them off. If I'm going to the hospital, I have to see a doctor. They come to realize that what you have to see is a clinician who is suited for the level of care you require, because we do not have enough doctors anyway. And therefore, if we do this and we do not train people properly, then we are also going to put pressure on the high-level clinicians, which they wouldn't be able to cope with, especially when there's a lot of health professional migration. And that is why I've answered your question by not just looking at the promotion of the fruit like the UK did, but to break it down to what they did with the fruit, how it impacted the younger generation, how they are continuing to do it in the supermarkets, and how this young generation is then picked up on their 40th birthday so that any chronic disease can be picked up quickly. In the meantime, while they are in the schools, giving the telltale signs of when they need to seek the help of a clinician. And I think a well laid out plan with this in mind would also improve Ghana's journey towards universal health coverage, which we've already signed that we are going to achieve it in 2030. But we seem not to do a lot in that term. So for me, that is why I am very enthused about this conversation that Dr. Da Costa has led us all to be having, because some of us have been agitating for it for quite a long time. But now there's someone in authority who realizes that the NHIS would benefit from such a strategy. But it shouldn't stop there. I think this should become an electoral conversation this year, and we should see commitment, because you must bear in mind that a lot of things fail in Ghana not because the technocrats are incapable, but because there's not a political will to back it. If the NHIS has to do this, then the cap on the NHIS funding ought to go, because you would have to, you see, it's almost like you cannot get all these people to go into the hospitals, so you would have to take health to them. So you realize that in festivals, like when you go to Ogbochocho, when you go to Drive their Shattery, interest and even to speed days in our matters and all that, they organize health screening. This is the sort of thing that we should be doing, but it should be linked into the hospitals. We can do it in the marketplaces, like if you come to the UK now, cancer screening, you be at the supermarket and you see a screening van parked there, which can do quick cancer screening. There are vans parked there which can do health checks. That is the sort of approach we need to have. We need to be very aggressive and intentional about this. And that's how I see it.
Dr. Yaw Osafo has sent some pictures of a case of breast cancer that was clearly left far too long before it was reported, and in fact I wish I could unsee these images. Truly gruesome. But that's what happens when you don't seek medical help quickly. And our health seeking habits are strange. Whether we're going to the herbalist or we're going to the actual doctor, we wait and wait and wait and wait for such a long time before we go. When it's time, there are many who might take the condition to a herbalist when it is at the point where conventional medicine needs to come in. and that also sometimes causes more harm than good. But look, let's try and wrap this up with these three big questions. Now, I want to start with you, Dr. Osafo. The NHIA wants to put the solution inside a hospital or a healthcare facility. So these health checks will be done in healthcare facilities. But we've already identified one of the big problems, and that is the fact that not enough people go to healthcare facilities. Mm-hmm. So, I mean, how effective can we expect the solution to be when it's been placed in the location people don't like going to? Do we have Dr. Osafo?
Yes, Kojo.
Yes.
Thank you once again. So we're talking about the effectiveness of any health promotion or health preventive activities or initiative. But let me take a few steps back. I think in all our conversation, we've been looking at the adult population. I stand corrected, but the pediatric age group is also very, very important. A few weeks back on the Dry Doctor show, I spoke about newborn screening. And newborn screening is also a form of preventative health initiative where babies that are born, on the day you are born, a blood sample is taken for certain diseases which can have detrimental effect on the development of the child. One example is congenital hypothyroidism, where the thyroid gland, which is at the base of the neck, malfunctions or is poorly developed, and therefore you don't produce enough thyroid hormone. This leads to maldevelopment of the brain, and the child becomes mentally retarded. This then we can intervene and solve this problem in the first 2 weeks of life if we screen and identify for it. Right. So I'm speaking on behalf of my pediatrician colleagues who most of the time we forget about the pediatric age group and we seem to think that disease tend to affect only the adult population or the elderly. Yeah. But please, in all of this conversation, we should not forget about the pediatric age group. They also need health screening and health promotion, and it starts actually from birth to the newborn screening. Right. Now, let me go on to the effectiveness of any plan that we are going to put in place. But for any plan to be effective, we need to properly define the challenge. So, number one, do we have a clear understanding of the disease burden in Ghana? And which of them are we interested in preventing? One of the things you shouldn't do is to spread yourself too thin. And I'm sure Kwame will talk about these things when he begins to talk about the numbers in terms of the money. Because if you spread yourself too thin, you're not going to achieve much. So what are the top 10 causes of mortality in Ghana? This is where our data collection and data aggregation and data analysis needs to improve. Thankfully, we're doing a lot of good work in that area, trying to implement the electronic medical record system. But we're not there yet. We're trying to use standardized classification so that we all diagnose diseases using the same nomenclature. It's been a big problem in this country where we represent diseases differently. I mean, could somebody will write diabetes and then just leave it at that? But diabetes mellitus and diabetes insipidus are two different medical conditions. But we would assume that when I say diabetes, we all know that it is diabetes mellitus. For those who look at the data, then it's a big, big, big problem for them. So we need to first and foremost be sure that in this country, Ghana, we know what the top 10 causes of mortality are. We know what, say, the top 10 causes of morbidity, OPD attendance, and so on and so forth. So the problem needs to be clearly defined. Then whatever it is, we need to be able to prioritize and say that, okay, you know what, these are the things that we can intervene. These are the things that, if we intervene, have a major impact on the health of the population. Then we'll come to the how we're going to do it. Kwame, a lot of it will have to start with the education. Yeah, people don't want to go to the hospitals. Okay, why? I think Kwame would speak to some of the why, and there are a myriad of factors. Some of them is financial. And again, that is where maybe the NHIA coming in. They're paying for it. I know, working as a doctor, some people, it's just too much for them. But you know the cost of insulin or diabetic care, comprehensive diabetic care. It's not cheap. Yeah. And there are children who have type 1 diabetes who have to be on insulin from a very, very early age. If you're looking at comprehensive care for a lot of diseases, then money becomes a reason why some people say, I don't like the hospital. Number two, we can talk about the lack of adequate facilities. So, Kojo, you come to a hospital, and to take an X-ray, you have to go to another hospital. You are given a request, and you have to go to another town, another district to take an X-ray. Yeah. It is very tedious and it's very cumbersome for patients. So that one-stop shop that has everything, very, very, very important that we have that type of system, because that is a put-off for some patients. And then for me, lastly, it is the attitude, unfortunately, sometimes of some of our colleagues, where, you see, when people are ill, it is not like you've gone to a restaurant and you are going to eat. Probably you are in a good mood, you are in a celebratory mood, so you can accept the little things that don't go well in that restaurant. But when people are sick, it's no laughing matter. When people are injured, it is no laughing matter. So we don't have to in any way make that whole experience in the hospital burdensome, get people angry and upset. So you are looking at delays, then you're looking at attitude of some healthcare professionals, and all these are contributory factors. So I agree that the hospital should not be the only space.
Doc, forgive my interruption. I think one of you has their radio a little bit too loud, or you're too close to your radio, so we're getting feedback.
Kojo, if you can speak up a little bit.
Yeah, I think there's some feedback coming from one of the three guests, one of you. You might be a bit too close to a radio, or the volume might be too loud. So we're getting an echo effect.
Okay.
So if you can move away from your radio sets, all three of you, please. If any of you is near a radio, if you can move away from it, so we don't get the feedback. I can still hear it, so that means that one of you is still too close to your radio. Prof. Abuosi, I don't know if you can hear me.
Yes, I'm hearing you very well.
Yeah, is there a radio near you?
No, I'm in my office.
You're in your office, no radio. And Dr. Osafo, I'm sure there's no radio. Kwame? No? Okay. I'm not sure where this is coming from. But please continue with your point, Dr. Osafo. Forgive my interruption. Hello, Dr. Osafo. Do we still have Dr. Osafo? Right. It seems we've lost Dr. Osafo there. Kwame. Yes. Can you walk us through, just top of your head, how much do you estimate we can save in this shift to preventive care with these free, yearly checkups?
Okay, Kojo, thanks. I just want to walk listeners through the conversation so they don't think that I've just picked the rabbit out of the hat, if that's okay. And it will be very quick. So Ghana's health expenditure per capita, that's the average amount that is spent per person per year on healthcare, it currently stands at $79. Right. And there are, based on our last population census and our growth rate of 2.1%, our population is estimated to be about 32.9 million currently in 2024. So if you look at that, it means annually we are spending about 2.6 billion US dollars on health. That includes out of pocket, what the government spends, and what our development partners spend. So if you look at the breakdown, currently the government is spending about 33%. Out of pocket is about 52% now, and the rest is the development partners. So let's look first at how much we would save totally, and then we'll look at how much the government would save. So if you look at the 2.6 billion, you realize that they say that a well-implemented preventative healthcare system saves between 20 and 30% of the total healthcare expenditure. So let's use 25% because that's the average. So if you multiply the 2.6 billion by 25%, it means that as a nation we'll be saving 651 to 652 million US dollars annually on our healthcare spend.
Whoa.
Then how much would the government save? The government contributes 32% of this. So if you then do 32% of that, the government is going to save about 210 million US dollars annually on its healthcare spend if this is done properly.
Wow.
So then when you look at it, that majority of the government healthcare spend when it comes to funding healthcare comes from the NHIS, then the NHIS is going to save annually 25% of its budget. And what can 25% of its budget do? They can then invest this 25% of their budget in useful investments so that when people go into secondary and tertiary care, this money can be used to fund them. That is one of the real mandates of the NHIS.
Yeah.
They have to invest some of the money that comes in. Currently, they are not able to do it. So this is how big the size of the cake is if we are going to do this properly. And that is why I wanted to talk everyone through. So as a country, we are going to save about 652 million, which then means that, Kojo, if 52% of the spend is coming from out of pocket, that means people go to hospital. And this is one of the, like Dr. Osafo said, this is one of the major drivers why people do not seek healthcare early.
Yeah.
Because they have NHIS cards, but it accounts for only 32% of our total health spend. So they, about half the time they are going into co-payment. So if they are going to save on that co-payment because we educate them that if they go in early, this is how much they are going to save. They are going to save about 25% of that spend. Then it is likely they are going to take this thing on. And that is why I'm saying that there needs to be a holistic plan from children, like Dr. Osafo started, through SSS, through medical economics, to actually talk the numbers through to a point whereby everyone understands. And that is why I insist that this should become a political conversation, because those seeking to run our health system should be able to talk through these numbers from the back of their hand and justify why that cap on the NHIS funding must go. Until people have these hardball conversations, then yes, Dr. Da Costa might have very, very good intentions. But unfortunately, if we are not careful, he would fail because he wouldn't get the backing.
Actually, just before I move on to Prof. Abuosi, let me ask you this, Kwame. This policy is being introduced by the NHIA. In terms of policy implementation, is this not something that we ought to be hearing from the Ghana Health Service? Does the NHIA have a mandate to introduce, such a far-reaching policy?
Yes, I would say they have mandate, because at the end of the day, they hold, by the law, the NHIA law, they hold the spending pegs. They have to pay for what the Ghana Health Service does. The Ghana Health Service has the mandate to provide us with healthcare. Yes, that is a clear mandate, and they are supposed to keep us healthy. But who pays for it?
Yeah.
And you must always remember the English adage, he who pays the piper calls the tune.
Indeed.
So as long as they are paying the piper, They cannot be sitting down sedentary and be spectators for the piper to be playing the wrong tune when it comes to the changing of the guard. That ain't going to happen. And we need a change of the guard in changing our healthcare behavior. So they need to be calling the shots because they are paying the piper.
Right.
And they need to ensure the right tunes are paid.
Right. Well, that leads me quite smoothly to my question to Prof, which is, can the NHIA actually afford to pay for one free health check per citizen per year? Can they afford it? Already, their record for paying bills is not great.
Thank you very much. What I think we need to confront about the NHIA indebtedness goes beyond the preventive care that we are talking about. There are a lot of problems about the inability of NHIA to pay its debt. Some of the factors are known, some are not too known. There is a need to take a serious look at the revenue mobilization and payment of providers, which is beyond the scope of today's discussion. Suffice to say that what the revenue that NHIS is getting is not enough, even if preventive care doesn't come in. So there is a need to the NHIS, which has done a lot, to be honest. It has really helped compared to the time of the cash and carry. But coming to the question of adding on the preventive aspect, as my other colleagues have already said, at the end of the day, there is going to be a net gain because prevention is always better than cure. And if they organize it very well and people are able to buy into it, and then there is cleaning and so on, and they reduce they prevent the diseases the non-communicable diseases that usually NHIS spends a lot on, then it's going to be beneficial at the end of the day, in the long term, for the NHIS. Let's look at what we expect when we are talking about a typical screening system. For instance, you need to know some of them are not very expensive at all. I mean, they are not even expensive. Clinical history, for example, they want to know your immunization history, whether there have been their BP status and tests, family history of diseases, past medical history, information about their workplace, their living conditions at home and leisure, and habits like drug use, alcohol use, smoke, exercise, sexual practices, use of seatbelts, helmets, all these things. They are not any expensive things. It's just a change of mindset. So if they are able to empower the health provider and shift the paradigm by from always looking for the strictly creative aspect that when somebody works into the health facility, the typical thing that the doctors will do and they have to go to lab and so on, they should include other services. I'm seeing the NHIA approach as getting the low-hanging fruit. People walk into health facilities with underlying conditions that because those are not the complaints, they walk out and nothing is done about it.
Yeah.
So, yes, when you look at, they go to hospitals and then they will take your vital signs like blood pressure, your BP, and that's all. What prevents the health facilities to take the height and then the weight. And then from the height and weight, they are able to determine the body mass. And when they determine the body mass, they'll be able to know whether the person is having a healthy weight or unhealthy weight and the risk of getting diabetes. This can be added to the traditional vital signs that is always taken by nurses. And it doesn't cost anything. Health insurance can even support with some basic equipment like weighing scales and so on that will let, health providers do these things. So some of the basic tests like BP and so on don't really cost
so much. It's just a paradigm shift. We need to also encourage the health providers to shift their paradigm from to curative mindedness to preventive mindedness, meaning that we need to now make use of dietitians and nutritionists seriously in health facilities. Some of the hospitals they already have them, but they are not being utilized. Meanwhile, they can give advice on diet and so on to hypertensive patients, diabetic patients, and so on. So we need to begin to take them on. What also goes into screening, like look at the physical examination of the head, the neck, eyes, and so on. Then they want to look at the blood cholesterol levels. Maybe those areas may need some lab tests and so on. The woman pap smear to prevent cervical cancer, breast examination, sexually transmitted diseases from the history. They will know those who are at higher risk of getting sexually transmitted diseases and offer counseling, cancer screening, especially those 40 years and above, including either the breast, cervix, prostate for males, and so on. These are, and then counseling, limiting of dietary fat, general nutrition advice, choosing tobacco cessation, drinking and driving. These are some of the things that will go into education. And I agree that I think Doctor wanted to say the other time, Dr. Sarpong said when he spoke that it should not just be limited to the clinic. You see, Ghana is very good with our public health system. We are one of the best practice countries in Africa as far as our public health system is. It should be incorporated. We have a lot of chief campaigns, community health nurses who go around and so on. I'm sure when they figure out the way to do it, some of the things that are easy to be done without people even going to the hospitals, they can be done. And then those that can be done in hospitals, like checking blood cholesterol levels and so on, can be done in the hospitals. I don't know the way they want to design it. But we need a complete paradigm shift. Doctors might change their attitudes, nurses might change their attitudes. We need to bring in nutritionists, dietitians, and so on into healthcare. We need to look at when people walk into hospitals, even they complain of malaria and they are overweight. You should be able to inculcate the assessment of the person's weight and the dietary advice given to the person, even though the person didn't report with that. And I'm sure that's what the NHIS is doing. So the cost of preventive care is far less.
Yeah.
And if we tune our minds well, it should be possible to do it without much. So after the cost, and the NHIS needs to really take a second look at your main source of revenue is 75% is from VAT. And we don't have jobs increasing and the population is increasing. And the premium is less than 50 cedis, and yet the cost of one health visit is over 200. It is unsustainable, and it's not necessarily because we are bringing on the preventive aspect in addition. We need to look at that separately, but we need a complete paradigm shift.
Yeah.
We need to tune our minds and to know that we are in a trajectory of moving away from the communicable diseases to non-communicable diseases, as the statistics show, and we better set up now.
Thank you so much for that. Just before we wrap things up, I think we've been rejoined by Dr. Osafo, who was completing his point just before we were interrupted. So, Dr. Osafo, we have just about 1 minute for you to conclude on this idea of placing the solution inside hospitals, when the problem is that people don't like going to hospital. Oh, we've lost Dr. Osafo again. I think we have some interference because of the weather up on the mountains, and so we've lost him again. We apologize for that, but a big thank you to Dr. Yaw Osafo, to Kwame Sarpong Asiedu, and of course to Professor Aaron Abuosi. All three of them have been very enlightening in our conversation today. We appreciate you all.